diagnosis is important. The tubercular infection when the TST or tuberculin is positive or IGRA positive, and tuberculosis not an infection, latent tuberculosis, MT positive. Other evidences are not there, clinical are not there, but X-ray may show granuloma or calcification, but no clinical symptom. So an active tuberculosis usually has fever, weight reduction, lymphadenopathy, hepatosplenomegaly, and pallor, weight decrease, and effusion, ascites, your pleural, even pericardial, and your there at times sputum positivity. Who are the risk groups? Protein energy malnutrition, crowded living, homeless people, institutional peoples in the nursing home, shelter, and other places, immunocompromised states like CKD, diabetes, cancer on cytotoxic drug, HIV infection, and under 5 immunocompromised child. So diagnosis is basically your even TST or tuberculin test more than 5 millimeter with known contact and the clinical features or X-ray evidence should be taken as tuberculosis. And when it is more than 10 in an predisposed person, as I said earlier, risk groups, it is also suggestive of tuberculosis. When risk groups plus has higher amount of dissemination, thereby when it is more than 15 without risk, it is also maybe tuberculosis. So interferon gamma releases, so the IGRA is preferred in below 5 years age group, and TST or tuberculin test is nice. Gene expert MTB and rifampicin in body fluids, in the serum, in the your blood, and in the other tissues of the body fluids, and then liver biopsy with tuberculoma compatible with the diagnosis. The MRI CT rarely needed. Monospot test is good. So despite everything, every effort to diagnose tuberculosis, because once upon a time it was a killing disease throughout the developing nation, thereby the diagnosis is important. It is treatable disease, infection. So antibiotic or anti-tubercular drugs are said to be curative. So if every step, every investigation, all investigation fail to reveal the diagnosis, you have clinical entity. Certainly you have the option, therapeutic option over here. The drug used over here are 4 drug therapy for 6 months in simple cases. In complicated cases, in some like many miliary tuberculosis, bone tuberculosis, joint tuberculosis, and tubercular meningitis and renal tuberculosis, disseminated form, you need to give longer time, 9 months, 12 months, even up to 18 months, even 2 years. So you give rifampicin INS and pyrazinamide and ethambutol, no response by 2 to 3 months, something. Highest you diagnose is your MDR, multi-drug resistant tuberculosis. Not that common, but it is possible. Usually higher amount of children or adults, they do respond within 1 month or so, and then no response by another 2 drug, the quinolones 1 and IV aminoglycosides, no response. You call it extended drug resistance. It's also possible in worst possible cases. These cases should be referred. Then it's supervised dot therapy, direct observation therapy with multiple agents, maybe 8, maybe with 12, a longer duration, and supervised, and see the response pattern of those cases in a specialized hospital with a very expert group in this field.